next session will be, I invite Dr. Jayalakshmi ma'am, the speaker. She will talk on labiaplasty, and the next panelist will be Dr. Deepa Kapoor, Dr. Pratibha Sharda, Dr. Jagriti, Dr. Pallavi Singh, and Dr. Madhvi M.
So good afternoon, everybody. Thank you, Bhopal. Thank you for inviting me. Thank you, Jamuna ma'am, for this wonderful talk. So every gynecologist should be able to do a labiaplasty. And all gynecologists should know that all vulva are normal. All shapes and sizes are normal. This wall is from the World Erotic Art Museum, where there are all shapes and sizes. These are all the wide anatomical variations of the vulva. Whether it is small, whether it is irregular, whether it is asymmetrical, whether it is just like a cleft, they are all absolutely normal. Just don't jump for a surgery just because the patient requests it. First, just like any procedure, we need to know why is the patient coming to us for a surgery. What are her real problems? Is it only cosmetic? Is it functional? Is it because she's not able to maintain her hygiene during the menstrual cycle, excessive sweating during exercise, during wearing tight garments? So just before any procedure, knowing the anatomy is of crucial importance. So the blood supply, the nerve supply of the labia are important. The anterior artery, the central artery, which is very important, the posterior, the first and the second artery. So what is a labiaplasty? It is an aesthetic surgery performed to reduce the size of the labia minora plus or minus majora to provide bilateral symmetry. It was first done by Hodgkinsons and Haight in 1984. Minoroplasty represents the majority of the procedures performed worldwide. And first, we gynecologists should counsel the patient as a psychologist and do the surgery like an artist. More than 75%, they are very happy because of the functional symptoms. High satisfaction rates are linked to the improved comfort and the quality of life. So prior to performing a minoroplasty, the Hart's line, the lateral boundary of the vulvar vestibule, it delineates the non-keratinized smooth transitional epithelium of the vestibule from the keratinized skin of the inner labia minora. The embryological significance, it is derived from the distal end of the urogenital sinus. While doing the surgery, we should not be medial to the Hart's line. So the classification for labial hypertrophy. The type 1, type 2, type 3 and 4. This is the Franco classification of less than 2 centimeters, 2 to 4, 4 to 6 or more than 6. This is Chang's classification from the Fauchett, and another classification. In this classification, we also see the modifiers for the asymmetry and the involvement of the clitoral hood. So when we see the vulva, the whole, the minora, majora, clitoral hood, everything, the perineum is taken into consideration. So what are the indications for the labiaplasty? Whether it is structural, functional or psychosocial. Structural, congenital, hypertrophy or asymmetry, and whether it is acquired during childbirth, aging or trauma, or whether it is iatrogenic. Functional, physical irritation, that is chafing and exercise interference. The hygiene challenges, the moisture trapping, which occurs in hypertrophy and excessive folds in the labia minora. Urinary stream deflection. This is a very important point. When there is a hypertrophy or any problem, when they have a stream deflection, then the patients try to strain more, and that will itself cause many more problems. The sexual discomfort because of the hypertrophy, postcoital irritation. Next, coming to the psychosocial reasons. Body image dissatisfaction, the sexual quality of life. So, the body dysmorphic disorder, do not operate. First, really go into the depth of it, whether it is a body dysmorphic disorder or she's having real, doubts whether she should undergo the procedure or not. She's just come for a consultation. It is very important. If she's having BDD, just avoid the surgery because she's going to be at the back of you for life. Next, the pre-op protocol, mandatory screening for active infections, informed consent with documented counseling on the realistic expectations, the risks, and a possible revision surgery. The pre-op markings are performed in lithotomy position to optimize the symmetry. Without a marking and while counseling itself, you need to draw it on the paper as much as possible to explain what you are going to do and is it really, on the same, is our patient on the same frequency as what we are counseling? Are her expectations different than what we are doing? The operative principles. Vulva should be approached as a single unit. Along with the minorplasty, does the patient really require a clitoral hood plasty and a perineal plasty also should be considered. The preservation of the neurovascular bundle for the sensation and the tissue viability. The application of the golden ratio. As I said, we are all artists. We have to keep this golden ratio while doing the minorplasty in the 1:3 width length proportion. So see in that pictures, after doing the surgery also, the ratio is maintained. So hypertrophic labia minora should be reduced and edges should be of optimal color. The instruments, sutures and anesthesia. Everybody has this. Everybody, all our labor rooms, all our theaters has this. No extra equipment is required. We do it under local unless the patient is very, very apprehensive and she wants it short general. Otherwise, it can be done under local anesthesia. The right procedure for the right patient for the right reasons. Every gynecologist should be equipped in doing at least minimum 2 types of minorplasty before going for the procedure. So what are the techniques? And no technique is superior to others, but we should have knowledge of all the techniques. The curvilinear excision, the wedge plasty, bilateral deepithelialization, zigzag technique, and the laser techniques. So the curvilinear trim technique. It is a linear excision of the protruding labial edge followed by a primary closure. Diffuse hypertrophy and significant asymmetry or edge hyperpigmentation. These are the patients which it will really work. But again, the disadvantages are also there. In this technique, there is predictable volume reduction and it is technically reproducible. When you are doing a surgery, prior marking, and if you are thinking about resection, you should always be probably 0.1 or 2 millimeters medial to where you're going to cut because the labial tissue retracts significantly. And all markings and excisions should be strictly lateral to the heart's line. You have to excise the tissue, never use a monopolar for excision. Either a plain blade or a scissors or an RF for precision. You can control all the bleeders with a monopolar, but never use a monopolar for cutting. Then meticulous dead space obliteration, approximation of the edges with fine subcuticular or interrupted sutures, and avoid tissue strangulation. The wedge plasty. This procedure was first described by Gary Alto in 1998. It is a full thickness excision either in the upper, middle or the lower segment. This works wonderfully well, but again, if the labia minora are very thin, this is not the procedure of choice. It preserves a mucocutaneous junction, decrease wound tension and decrease in dehiscence. The extended wedge techniques are the honey stick wedge and the star wedge. Bilateral deepithelialization, you can preserve the subdermal and the neurovascular structures. Mild to moderate hypertrophy, this is the choice of procedure. It maintains the natural rim, but this procedure is not suitable for severe hypertrophy. The zigzag technique, mild to moderate, again the marginal scar visibility is there. Laser labioplasty, the labia is cut with a laser probe either with a CO2 or diode or an RF, mild to moderate hypertrophy, and it's a bloodless surgical field, increased precision and decreased post-op inflammation. And without mentioning Red Allen Sort, this topic is never complete. He's the Barbie look minoroplasty, which involves a complete concealment of the minora within the labia majora. Phases of wound healing, this we have read in physiology. The importance of this is, once we are doing a surgery, and especially in the minora, there is a lot of edema. So we have to counsel the post-op recovery timeline. There is a peak edema in the first week, bruising and itching. This is a normal inflammatory phase. Second week to the fourth week, there is asymmetrical swelling. The patient will run back and tell you, what is this? I've come for symmetry. What is this? But then reassure her. After 3 months, there is nice tissue softening and remodeling, and after 6 months, it's fantastic pictures. So this is a post-op edema, and these are the scalloping edges. This is a fenestration and hematoma. These are complications. The before, immediate post-op, and the 6 months post-op. The before and the after picture in this case. The satisfaction rates for the deepithelialization, wedge and trim. This study was done in 2024, but if you see it, it is just 97 and this is 95, so not much of a difference. Thank you so much.